this week on the BackTable Podcast.
That's the other thing I love about carbon dioxide is my trocar is not going to freeze. So I can park a Ganji needle on my ice ball and convect CO2 as much as I need. And I'll see that skin visually puff up. And I'll periodically scan with CT in those cases because my ultrasound is not as useful. And I'll feel with my gloved hand to make sure that it doesn't feel cold to me because it's numb skin, so you're not going to get that biofeedback. We talked about a lot of things just now, but we basically summarized skin protection, especially for cold, strategies to address some of the hardest cases, which are post-radiation scar, post-surgery scar, hydrodissection, hydroconvection, needle strategies, pump setup, tubing setup, and then how to troubleshoot drip issues and visualization of your protective layer.
Hello, everyone. Welcome back to the BackTable MSK Podcast. This is your host, Jacob Fleming, and my guest today is none other than longtime friend and colleague and veteran of the show, Alan Sog. Dr. Sag, welcome back to the show.
Jacob, thank you very much. It's so great to be back. And I really love the BackTable Podcast. This is something that I listen to very frequently, and I find it useful. And the reason that I love this podcast very much is because I feel like it speaks to people from all experience levels, even those who are in training. And so thank you for having me back.
Absolutely. Always good to have you back. And of course, you were one of my very first guests back when I had the opportunity to start doing podcasts a few years ago, building an MSK Oncology service line. Great discussion we had a few years ago. And we're kind of building on that with our topic today on thermoprotection. But before we jump in, congratulations are in order. Since your last appearance on the show, you've been promoted to associate professor at University of Miami. Congratulations. And also a fellow of the Society of Interventional Radiology. So congrats on your accolades.
I appreciate it, Jacob. Thank you very much. Very honored for that. And, I'll tell you, one of my favorite memories on BackTable was when we were at CIO doing the cryoablation one. Downstairs, no sound engineer, and just being interrupted by, passersby.
Constant stream of passersby,
people who recognized you, or some who recognized me, more who recognized you, and just interrupt in the middle of an actual podcast. So that was a lot of fun.
Fun times. So today we have a little more of a controlled setting. We got our connection issues out of the way a little bit earlier on with our first run through. But so we're gonna jump into the topic of thermoprotection for ablation, basically. So super broad topic, and we're gonna go over kind of all the basics and get into some more specifics. Of course, today more specifics on musculoskeletal, soft tissue, and spine type of ablations. But these concepts apply pretty much universally, regardless of the location. And so first of all, like you said, we try to appeal to listeners of all experience levels. And so just diving into the big picture, what is thermoprotection?
So thermoprotection is the principle of when you are ablating a target, making sure that other things that are in the neighborhood are protected. And this applies to, we're going to talk today about hot and cold ablation and things that are not ablation. So cement, which is also exothermic, when it polymerizes. And I really want to speak to people who are about to do their first case. And I also want to speak to people who maybe have been doing this for a while and are about to undertake a pretty difficult case that's maybe in the vicinity of the spinal cord or other structures like bowel or skin, and go over some of the principles with updates as recently as new things I saw at CIO this year, which was just a couple of weeks back. I saw an interesting update there that I'm going to include.
Sounds great. So, we can broadly define or delineate thermoprotective strategies into passive and active. So how would you describe those separately?
So active, that's a great question. And so whenever this topic, by the way, the topic of thermoprotection comes up at every major meeting on the topic of bone and soft tissue. So when you go to MSK Masterclass this year, there was a talk on thermoprotection. Even at Guest last year, there was a talk on thermoprotection. And I would say that one of the key divisions is whether you are simply measuring the bad temperatures or the good temperatures, or whether you're doing something about it. And I would even divide it into three sections, which is passive, active, and mitigation. So passive thermoprotection is everything from biofeedback, which is just a very fancy way of saying the patient's awake. I'm taking a look to see if they're reacting to hot or cold temps. If I'm next to the sciatic nerve, I'm maybe having them plantar flex their foot to test out motors. So biofeedback is anything that the patient can cooperate with. That also means that the patient's going to be not completely sedated, or the area is going to be perhaps not totally numbed. Other things that fall within the passive thermoprotection bucket are neuromonitoring. So we're going to talk a lot about neuromonitoring. Hot topic, not just because of us in IR. Actually, neuromonitoring is a hot topic outside of IR. The application of neuromonitoring in IR is a relatively recent topic in our history. Relatively recent, we've started to incorporate this, and the strength of neuromonitoring at your institution is going to be dependent a lot on the neurology and neurosurgery and orthopedic surgery programs there. Finally, the passive thermoprotection includes thermocouples, so measuring temperatures, like actually getting the data. There are probes that can do this that come with hot and cold ablation systems that we'll talk about. And then watching for ice, watching your 0 degree line. So seeing where your ice is, even though the 0 degree line is not necessarily lethal for cancer cells, you can cause a lot of damage at 0 degrees if you're next to something that cannot tolerate that temperature for an extended time, such as colon, skin, or certain nerves. And then you've got active thermoprotection. So active thermoprotection, you're doing something, and you're typically infusing either fluid, and that fluid can be dextrose if you're using RFA as a way to not induce spread of electricity using the ions that are in saline. It could also be air. So you could be infusing air, so the carbon dioxide or room air, and we'll talk about when to use which. Specifically, just to spoil that, I have found that carbon dioxide under the peritoneum is a little better tolerated compared to room air at higher volumes, although it is reabsorbed faster, and that's relevant to sarcoma ablations in the abdominal wall, for example, where you need non-dependent thermoprotection. Another active thermoprotection term that I use sometimes is hydroconvection. And we're going to talk about that for the challenging cases that are post-radiation, post-surgery, lots of scar, can't get enough lift on the skin. So you're parking a needle under the skin, typically avoiding making a lot of incisions so you don't have a lot of leak points, and then using usually a pressure bag hooked up through IV tubing that is continuously convecting or delivering fluid over a space in order to correct either hot or cold temperatures. So hydroconvection, this was not in the literature until I think a few years ago. There's a brief report in JVIR that talks about hydroconvection. And then we'll talk about, mitigation. What do you do? What can you do immediately on the table? What kinds of consults should you be thinking about? And then I think actually a really big part of this, and the reason I think this is a relevant topic for anyone listening, is if you're about to undertake these kinds of cases, planning all this out and then knowing what the risks are and then having a very insightful discussion during informed consent goes a long, long way.
Absolutely. And very frequently, we're performing these procedures for patients who otherwise don't have, great other treatment options. I would argue that, there's probably a lot of times where these should be offered, prior to that when, we're not in a situation where all other options have been exhausted. But that's kind of classic for interventional radiology, being sort of last resort. And so you have to be able to discuss all the potential things that can happen. And like you said, a lot of times that is highly dependent on the specific case that you're looking at. And so my very first cryoablation case was a ganglion impar, and I was very lucky. Yeah. I was able to talk to some colleagues, including Alexa Levy, and so this is a inoperable recurrent rectal cancer,
Sure.
kind of plastered up pretty close to the ganglion. And of course, I didn't want to actually cause damage to the rectum itself. And so had to be able to break out these techniques, not really having experience doing something that was a little more straightforward. So that tends to be how, in my first year or so as an attending, it seems like, the tough cases will find you. And so it's up to you to know, is this safe to do, or, what techniques to employ. So hopefully this is something that gets across to our audience today. I've surely found that being aware of the techniques that are available certainly changes how you approach talking to the patient and what you will be or will not be willing to offer treatment-wise.
Yeah, Alexa is fantastic, by the way. I really liked her BackTable on cryoneurolysis. She's
great.
She's an amazing speaker too. I've heard her speak at many conferences. And that case you mentioned, I mean, I'd love to jump right in with that case, because there's a lot that can be said about ganglion impar. But you mentioned something earlier which is so key, which is that how many times are we the last option that's thought of? But it's actually a privilege that we can be the last option because we are non-ionizing. So unlike radiation therapy, we are not an ionizing therapy. So you usually reach radiation dose limits. Probably that and other societal efforts and the motion study contributed to this FDA clearance. So we are FDA cleared for cryoablation for bone mets that have been irradiated and still have persistent pain. And we know that is something that frequently occurs in our patients. I would say the initial studies, the initial Cochrane review on old radiation therapy for pain palliation, which I think included a single 8-gray dose, had up to a 40% non-response rate. Now, there are newer dose strategies for radiation oncology, and radiation oncology is generally safe in this space, but we also don't have to interrupt systemic therapies. And so we recently published this year, actually, our series on non-interruption of systemic therapies during cryoablation, because the wounds are so small. Really, you're making if you're even making an incision, a lot of these probes are sharp. Some people just send them through the skin. I tend to make a very, very small stab incision with the blade, typically 2 or 3 millimeters in depth, just to get through the fascia. And that I find that at the end, when I do my closure, which is typically glue and a steri strip for these smaller ones, I find that those really heal nicely, especially for patients who are on different systemic therapies. So I think, just like you said, this thermoprotection topic is especially relevant for some of your high stakes cases where your patients are on systemic therapies and you're ablating something that's close to skin. If you get a skin ulcer, and we'll talk about how to avoid skin ulcers, a lot that we can say about that.
Yeah.
It's several weeks of wound recovery in some cases, and it can kick them off of the systemic therapy for a while.
Sure. So why don't we actually talk about that a little bit? I think it's good to think about potential complications of going in, and we were just talking about informed consent a moment ago, and it's good to think about worst case scenario and have kind of plans for that. And you've outlined a few here for us. So why don't we kind of jump in? And so just talking about the topic of basically skin injury. And so what are the situations where this can potentially arise? What mitigation strategies are you using? And worst case scenario, how do you handle that if you have an ulceration or other type of injury?
Definitely. So the topic of skin is going to get more relevant for us ever since the newest soft tissue sarcoma NCCN guidelines. So those guidelines say that for desmoid tumors, we are the preferred ablation technique when technically feasible. And that specifically applies to extra-abdominal sarcomas. And so these are all abdominal wall, chest wall. We know that there's a recurrence rate with surgery and radiation for these. And so that's why our minimally invasive techniques are very helpful. And sometimes for these can be very large. You're creating a large ice ball, and your injury can occur during the procedure, and it can also occur after the procedure. For example, if you're creating a very large ice ball, that can take up to 30 minutes in some cases to totally thaw. And if you have just done a large pneumodissection, and we'll go through perhaps like a case of an abdominal wall lesion and what positioning and different techniques we might use. But just to cut to the chase, if you've got a large ice ball and your carbon dioxide gets reabsorbed and the patient's in recovery and their bowel comes up and meets that ice ball as it's still thawing, you could get a bowel injury in recovery and not even be aware. Similarly, if you've just frozen something that's on someone's back and you had a very thin layer of fluid, or you could only hydroconvect because you can't lift the skin, perhaps because they've had a flap or they have had radiation, you can't get that scar to stretch. So you create a big ice ball, and then they roll supine in recovery, they're laying on that ice ball. Their skin may come into contact with the ice as it's thawing. So there are things that once the case is done, there's still potential for injury that needs to be considered. I would say the first thing starts with a physical exam. And in an age of televisits, a lot of times that's sometimes difficult depending on the practice setting. But you can look at if an area has received radiation, it's always worth considering the fact that you may not be able to get a lot of lift. And what's a lot of lift? Ever since the RFA literature for kidney ablation, like the Dr. Gervais times over a decade ago, where we were talking about what's the minimum safe distance between kidney and bowel for RFA. And there was a number that we all learned in training, which was about 1 centimeter for fluid. In general, if I can get that much distance between my 0 degree line, I'm talking about ice, because that's frequently what we use for sarcomata and for larger soft tissue ablations. If you can get 1 centimeter between that and the dermis, which is the layer just under the epidermis on ultrasound, and if you get subcutaneous and you're injecting a lot of fluid, you'll see that rise. I like to maintain it about 1 centimeter is ideal. You don't always get that. I will say that when you start injecting that much fluid, it's going to be visibly very apparent, and it's going to look like a lot of fluid. And that fluid will reabsorb in the patient. And I would endorse that by physical exam, you should see what is the skin turgor? Is it very much attached? And sometimes you won't know until you try to lift it. And it might feel kind of rigid, and then you get it. I like to test it out first with a 25 gauge needle hooked up to the IV tubing that has the roller. The roller is great because then you can be hands off, right? You hook that up to a tiny needle, you get it under the skin, and you pump up the roller. Now that is continuously infusing while you're doing other things. What are you doing? You have a linear ultrasound probe ready. Why is that relevant? Because you could use your own hand to touch the skin while you're growing that ice ball. But if you're using fluid as your protective measure, then that preserves an ultrasound window. So many times I will specifically opt for fluid just so that I can monitor a large area of skin quickly during the ablation. If you're in CT, you could go up and down and scan multiple slices, but with ultrasound, you can scan the whole at-risk area. And what is the at-risk area? I've found that sometimes it's the tails of your probes. Many times that tail ice, we're all expecting the lateral growth of ice in each direction, but the tails can be unpredictable. And the marker that's on the back end of the heating element that you see the cryoprobes that have the heating elements built into them, there's a little thin radiolucent line. That's not intended to show where your ice will end, but for a single probe case, I find that the tail is typically within a few millimeters of that. If you have multiple probes in, your tail could extend, your 0 degree line can extend about 1 centimeter, and I'm sure you've seen that in some cases too. Behind that line, there is actually a skin safety marker on the particular vendor of probes that I use a lot of. And if that skin safety marker is visible, then that's another visual cue that we need to either puff up the skin with some fluid or readjust our geometry or our angle of approach so that it's not exposed. The reason I like to start with a 25 gauge is because it's low commitment. So if you're creating an incision, you're putting in a UE or you're putting in, I'm not a consultant for the Ganji HydroGuard needle, but you're going to hear me talk about it a lot. Actually, just yesterday we had the guest cryoablation summit, and I think I mentioned it like 5 or 6 times. So this needle is similar to the Varese needle that Rob Sue talks about for lung, sort of pleural fluid infusion and other chest wall infusions. And the Varese needle is what's used for pneumoperitoneum initiation in surgery. And it's a blunt end with a recessed side hole. So a few millimeters from the tip, it has a side hole that shoots out a jet of fluid. And the reason that that's good is if you're digging through fat with an end hole catheter, or for example, the introducer needle for a 1718 coaxial biopsy kit, some people will use the 17 gauge introducer there because it's metal and you have some steerability. You can core fat on the way in and it clogs you, and then you may not be infusing. And depending on how critical the circumstance is, if you're mid-freeze and you need to do this as a rescue maneuver and you need fluid in now and you hook it in and you just dial it up, you may not know that it's not infusing unless you scan immediately or you see that the drip is not dripping and the IV pole drip. And so I really like the end hole because it doesn't clog with fat. It also has directionality, so you can point at the skin or you can point at the ice.
Gotcha.
The Ganji HydroGuard needle, and it's the same spelling as Dr. Afshin Ganji for his name. This is a Seldinger style access needle, which has an introducer that you then replace with the recessed side hole blunt tip. I love the blunt tip because if you're in the abdomen and you have a very small landing zone deep to peritoneum, you can navigate bluntly near bowel, near vessels, and you have that added safety. Whereas what some people did prior to the availability of this needle is they'd go in with a sharp needle that has an inner kind of sharp stylet, and they would recess the stylet. They pull it back partially and expose that end hole and then just bluntly go. But then that's where you run into the coring of the fat issues, clogging your hydrodissection trocar. So I love that needle, but if you're going to introduce that needle, you're typically making an incision. And in your hardest skin protection cases, the ones that have a lot of radiation, oftentimes you're not going to be able to get enough lift. And that's where you get into hydroconvection as opposed to hydrodissection. And the fluid will go the path of least resistance, and that's many times not where you want it to go. So if you create a lot of incisions and if you don't use them, then they're just portals for your fluid to leak everywhere. It makes the field really, really wet, and it's inconvenient, and it's inefficient because typically I'm doing a 1:50 mix on the fluid. That's actually been published, by the way. Contrast ratio for optimal hydrodissection visibility that doesn't streak out your structures is 1:50. So 1 milliliter of contrast for every 50 milliliters of saline. And I'll typically start most cases with a 1 liter bag. And rarely I'll need more than that. The times that I need more than that, in the MSK space, it's uncommon that I need more than that. But if I do, it's typically like a lower pelvic abdominal wall where I'm doing a lot of fluid, and there's a lot of places for the fluid to go that are dependent and away from the target. So I have to constantly infuse to replenish. And then hooking that up to the pressure bag, pumping that up to the red zone, so the highest pressure is what I typically do. That much pressure is often what you need to create any degree of separation in these irradiated fields. And so essentially hooking that up with the roller and watching the drip and keeping an eye on that drip. If you don't see it dripping, one of three things has happened. Either your line has frozen, which is very possible, especially if you're using fluid and you're parked, your hydrodissection trocar is parked near the ice, and the flow is slow enough, you can freeze. And then you have to put in a new needle, usually. The second thing is your fluid may have run out. And that's sometimes hard to tell because the way that the IV pole is hanging, it's usually out of the visibility directly. And then the third thing is you may have an occlusion due to fat, or your needle may have moved out of the place where you think it is when you were doing other things. It may be no longer in a space where it can infuse. And so I keep an eye frequently on that infusion drip. And these are some of the keys to protecting skin when it comes to cold. When it comes to cold, by the way, the skin starts getting injured if you're below 15 degrees for a prolonged period of time. Below 0 degrees is where actual frostbite occurs. And technically -5 degrees is where the skin surface will freeze. And the ice crystals will cause thrombosis of, the microvasculature, and they cause ischemia. And many times we're using Lido with epi. So we're already vasoconstricting the skin, right? I love personally Lido with epi. I think it creates a bloodless field. It's very obvious where I've numbed because you get some blanching. And I will typically dilute it with saline or D5 or bicarb. If I'm feeling fancy and we have bicarb, then I'll use bicarb, but the other ones work too. And as you know, the speed of onset of numbing relates to the number of molecules. So if you're using Lido 2%, it's going to have onset twice as fast as Lido 1%. The duration is based on the chemistry. So when you're diluting it, it's going to take a little bit longer to kick in, and it's going to last the same duration of time. But that reduces your biofeedback. If you double glove, your hand may be less sensitive, but I'll also say that your hand can be a good active warming strategy for the skin. Many people like to use warm gloves as an active thermoprotection measure. I find that putting the warm saline into the gloves and tying them up is laborious. It's a little bit messy. Yeah. Have you ever done that technique?
I haven't, but I've asked a few colleagues about that, and I was like, how do you go about that? And one of my colleagues told me, I don't know, I just had the nurse do it. And I'm not really in a setting where I can just say, hey, do this thing, I don't really know how to do. So it's something I haven't personally gone after. I mean, it looks nifty, but I can see how that's laborious.
So I like how it looks on scans because it looks kind of like the Michelin Man, and it looks like, and you feel safe. But you have to, if you're using it, you have to occasionally like agitate it, right? Because the temperature settles in there, so you want to mix it up. What I have done is heat packs. The heat packs that you crack.
Sure.
Those are not sterile, so you have to kind of put them into something sterile, either an II cover or a sterile glove, and that's laborious. And then occasionally you'll have a mist drop, and then your gloves will get contaminated. You have to rescrub. So it's less convenient. So in terms of active warming, I like hydroconvection, which I think keeps it all under the skin with minimal skin incisions. 25 gauge needle is a good test for that. And then Ganji has the Ganji needle has the authority you need to really get more lift and more fluid in. But there's gas, right?
Mm-hmm. Yeah.
And so gas is actually published. There's now a publication by Maybody et al. When I was in training, now it's been a decade. But when I was in training, we used to do this and it wasn't published. And so now the publication comments that in HEPA filtered rooms, you can use room air. So specifically, they used room air in that publication. It's the Maybody et al. Publication. I really like the CO2 Commander. I kind of love the CO2 Commander for a few reasons. One, you can sterilize the system, and I have full control, and I typically put it at the foot of the bed. And it's the same system that we use for CO2 angiography, so most places already have it. And it's filtered, and those cartridges last a really long time. And the only downside to carbon dioxide and air is that you will lose that ultrasound window.
Right.
The major two upsides, so they're actually units of thermoprotection. There's like a unit of how much energy it protects and insulates. It's an order of magnitude more insulating than fluid, gas. So I'm willing to accept a much thinner layer of gas compared to fluid. And this is the principle behind air gaps in house insulation. And by the way, keeping the fluid dripping and preventing it from dripping, that's the principle behind keeping your pipes dripping in the winter, right, if you're not going to be home for a while, right?
It just goes back to the old adage, IR is really just fancy plumbing, right?
Fancy plumbing.
That all comes back to it. Yep.
It sure is. But you can't freeze. I think Dr. Kallstrom once mentioned at one of the meetings, they have a joke that you can't freeze air except in Minnesota. And I love that joke. But that's the other thing I love about carbon dioxide is my trocar is not going to freeze. So I can park a Ganji needle on my ice ball and convect CO2 as much as I need. And I'll see that skin visually puff up. And I'll periodically scan with CT in those cases because my ultrasound is not as useful. And I'll feel with my gloved hand to make sure that it doesn't feel cold to me because it's numb skin, so you're not going to get that biofeedback.
Right.
So we talked about a lot of things just now, but we basically summarized skin protection, especially for cold, strategies to address some of the hardest cases, which are post-radiation scar, post-surgery scar, hydrodissection, hydroconvection, needle strategies, pump setup, tubing setup, and then how to troubleshoot drip issues and visualization of your protective layer.
Yeah, that was awesome. That was a lot of great information. And so while we're on the topic, really more so focusing on skin at the moment, let's talk about, how to handle a potential complication. So how are those typically going to manifest? Are you going to see something right away necessarily in recovery, or maybe not until follow-up?
I've been called into the room for a couple of these along the way. What you will see is ice that the skin is hard frozen, first of all. And I will say that when the skin freezes, if you see the skin is frozen, that is most likely going to ulcerate. It may be a small ulcer, but most likely what that's going to become after the case is erythema, and then it'll slough. And the reason I mention this is because the time to engage wound care is in PACU for those patients. Those patients are definitely going to need wound care. And the reason that these wounds are very problematic is because they're typically full thickness injuries from below. And so they often require healing by secondary intention with a lot of dressing changes. They thankfully are often not very painful for the patient, depending on the circumstance, because it's a full thickness freeze of all the structures in the way. But because many of these patients are on chemotherapy, it can unfortunately create an issue where they either have a prolonged wound healing, or especially if they're on a VEGF inhibitor, or it can create a lot of concern for infection, especially because they can have exudates that look like pus, essentially, and especially if you're giving steroids or if they're on steroids for other reasons. Patients are on steroids for a variety of issues like cord compression or other places where they're getting steroids to reduce swelling. And so it can kick them off the systemic therapy for a period of time. So it's really, really important to actually minimize the risk of that happening. It can happen quickly too. So I think, because if you're growing your ice ball at 100%, and say you shut off the ice, say you shut off the probes, like you're getting close, and it's like, oh, it's close, I'm going to shut everything off, and you put your hand on the skin to warm it. That ice, and I'm sure you've seen this too, that ice is going to continue to grow. And the reason it grows is because the cryoprobe works by creating a heat sink at the source where the probe is, okay? And just like the Lannisters, that debt always gets paid, okay? That temperature debt will be paid, and it will be paid at the expense of the structures around it. And that heat sink is that's why your ice continues to grow even when you turn off the probe. You can move into active thaw at that time. That may help. But I find that if you are approaching skin, your fastest, easiest solution is 25 gauge needle in, room temperature if it has to be fluid, directly on the target. And depending on where it is, you may not even need image guidance. And you'll probably feel the ice ball under that 25. I actually did a lot of this. I don't know if you remember, a few years ago, we published this series of cryoablations in the neck, where we were cryoblading. The whole paper was where we cryobladed tumors that were adherent to the skin and or the carotid and jugular and or the trachea.
Very casual. Just another day at the office. Yeah.
As one does. And this gave a unique opportunity to watch ice form. And you can only see the non-dependent side of it, right? Because you can't see through the ice ball. To watch ice form and to watch how ice responds to hydrodissection in a way that probably, unless you're doing it in such a focused fashion with ultrasound dependence, you're often not seeing how it reacts. And what I saw there was very interesting. So first of all, these patients had well-differentiated thyroid cancers, and they were in the neck, high-value real estate in terms of crowded vascular structures, stellate ganglion, a lot of issues with Horner syndrome risk, and a lot of post-surgical scar. 25 gauge needle in to do the hydroconvection, but the neck is also a contained space, so the fluid doesn't want to stay there. It's going to go south. Typically, it goes south. It doesn't have much room to go north. But you can't infuse too much because then it compresses on the airway and stuff like that. I watched as the fluid went onto the ice under ultrasound, and it starts to chip away at it immediately, and it's very responsive. At 0 degree line, you can shave it down pretty quickly with a jet through a 25 gauge needle. I would also say that if you have air and you're seeing that the air layer is safe, and if you can get air under the skin, that's a very good rescue maneuver as well. If it's a very small area, I've heard some people talk about just primarily excising it, suturing it to create, a wound that heals by primary intention. I believe that the wound that forms from this is a little unpredictable because your zone of ischemic damage is difficult to predict if you have Lido with epi on board, how fast you have warmed it up. It's tough to say that if it reaches this temperature, this much skin is definitely going to die. And there's also a duration. When we get to nerve, for example, we'll talk, it's not just absolute temperatures, it's duration of exposure as well. So if you catch it right away, there's a chance you can rescue it. I would say that if you predict that this is a risk, you should have a discussion with the patient. Sometimes it's fully acceptable. I remember someone was telling me a story about a case that they did where the patient had a painful tumor, exhausted all treatment options. Cryo was the only option. They wanted pain relief in their final weeks of life, and they were willing to accept a wound and the concomitant wound care that comes with that. So I would say if there is a risk, discuss it and make sure that everyone is on board with that, and maybe even find out how you're going to reach the wound care specialists if they're going to be available, and maybe even go the extra step of making sure that they have a follow-up appointment set up beforehand that can always be canceled. What does wound care do? They work magic. So they have a lot of specialized. Have you worked with them before as well?
Yeah, so my primary exposure with wound care was actually in a totally different context. Of during fellowship, we did a lot of pain pumps, and unfortunately, you run into situations where sometimes a pump may need to be removed, or you start to get an ulcer over it. And there are multiple times where they, like you said, they work their magic, and the pump doesn't have to come out because they use all the different things in their armamentarium to get a wound to heal over. And we see this a lot, and it primarily never had anything to do with the surgical technique, but just certain types of patient populations, especially patients with diabetes, patients who are on, steroids, like you mentioned. So there are just certain types of patients who are seemingly more prone to wound complications. And even in those situations, wound care is just invaluable and very frequently able to salvage something that otherwise may have been pretty hopeless.
It's a tough job. I envy their strength in doing it, and I've only had great interactions with wound care specialists. And what I would say is they have a lot in their armamentarium. They know how to keep things. They know when to keep the wounds dry and when to keep them wet. They have a lot of specialized dressings that many of us have never heard of. They're made of things that we've never heard of. And they also know that they know the downstream things that are available, like hyperbaric chambers, when to make the recommendation. And so I think that when it comes to skin, avoiding the injury is always more helpful, even if that means that you're potentially under-treating an area. And so let's say, there are times, one of the things that I was going to talk about later, but I can talk about it now, is in IR, we have a lot of tools. So you can potentially do an embo cryo, especially if you think that there's going to be an area that's close to nerve, close to bowel, close to skin, where you may not get good over coverage of your 0-degree line, where you may augment that cryo response with a pre-op embo, and you can see with contrast staining what areas have been well embolized, and then you can perhaps focus your cryo on the other areas. And then especially for very large desmoid tumors, where you're most likely going to have to either stage the procedure, because when they're so large, I'm talking so large to the point where it's like 10 centimeters, and you're going to be probably admitting them for hydration so that you're doing nephroprotection, because there's going to be a lot of tumor death at once. In some of those cases, you may consider augmenting your response with embo. A little bit of it depends on the tumor vascularity as well,
for sure,
and how efficient you can deliver. And also, it's always a challenge if they're parasitizing from the skin and you go too small with your embolic. It can always have the opposite effect where it injures the skin. So I think for skin as well, we don't talk about hot ablation near the skin a lot. Typically we're going cold, but we start to perceive pain at about 109 degrees. So when you touch the stovetop, you get a superficial burn just at around 110. And what happens is the proteins denature, and then the cell membranes get disrupted and you get cell death. And that's actually why mostly in construction for house water supplies, they keep the temperatures in the sinks and the bathtubs, less than 48 centigrade. For an instant burn, it needs to be 69 or higher, but you're numbing the skin, so you may not get that biofeedback. The one challenge is microwave will heat fluid. So you should rely a little more on pneumo as opposed to hydro-dissection if you're going to be microwaving or RFing very close to the skin. I will say, in the thyroid RFA space, especially for isthmus ablations, we're relying heavily on dextrose convection for those cases. So convection is great. If the fluid's moving, that's fine. But just a static fluid in that space, I would feel less safe for that. I would say that convection would be a better strategy for heat. But again, when we're heating, most of these targets are very deep. And I would say because of how well cold is tolerated from a pain perspective, post-procedure, for the purpose of this podcast, where we're talking about bone and soft tissue and nerve, cryo is the much more relevant option.
For sure. Well, I think we've really talked about a lot of different elements pertaining to the skin, and obviously a lot of this carries over to different critical structures. Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.